Do you have SIBO and want to learn how to help yourself? The SIBO Success Plan is now available from thesibodoctor.com. In this highly anticipated plan, you'll learn my tried and proven method to treat SIBO, including home treatments, online dispensary guides, diet handouts, and much, much more. Already being treated by a practitioner? No problem. The SIBO Success Plan is designed as a standalone program or to work under the care of a practitioner. Become a SIBO-savvy patient and beat SIBO for good. For more info, go to www.thesibodoctor.com. Welcome back to part 2 of the SIBO Doctor podcast, and let's jump right back into it. Now, moving towards other types of parasites, and my first question would be, what do you most commonly see in your practice? And I'll preface this by saying that, I just don't see that many parasites in my practice, and I do a lot of stool testing. I see it very rarely, and I wonder if that's part and parcel of this decimation of the microbiome, is that we have lost some of these other species. And obviously, we're certainly not saying that parasites are a wonderful thing to have on board for everyone, like tapeworms and cryptosporidium and toxoplasmosis. No. That's not what we're saying. But we started off with the harmless neighbors, or the ones that don't seem to be causing a problem. So what would you say? What do you most commonly see after these two? Because they are very common, I would say. Those are the only ones. Yeah. I
agree, and they certainly come up frequently. I tend to just note it in my notes, but don't focus on them at all and keep looking. And generally, we'll find what's causing symptoms in these patients in that scenario. I said that's almost always the case. But I would actually put Giardia on the list of the ones that probably comes up next. And that one is, I would put in a different category, that when it's present, someone has symptoms, I'll generally assume that's the cause, and treat it. And luckily, with using the right natural medicines, you can usually eradicate Giardia in 10 days to 2 weeks, pretty consistently.
Pray tell.
Yeah, and I'm lucky because I started off practicing up in northern New South Wales where you are, and I think I was working where remember those rainbow gatherings that would happen, and I think you'd have these floods of people with Giardia after certain rainbow gatherings, and had a chance to do lots of trial and error on patients and see what actually worked. And I still see them less commonly now than I did up there, but still it's probably the most common what I'd see as a real disease causing protozoal in the gut of my patients. And I think it does respond really well to some dietary changes like reduction of fat. Actually, fat is a huge thing with Giardia. That one, it induces symptoms because you get this fat, massive fat malabsorption with Giardia, because Giardia multiplies so quickly, it covers up pretty much your entire absorptive capacity of your small intestine. It's just loaded with, every millimeter is coated with these little Giardia. So you malabsorb fat, eats bile as well, and actually likes bile to actually grow on. So you malabsorb the fat, you end up getting worse nausea and steatorrhea if you eat sort of a higher fatty sort of food. And it also tends to go better on, this is one of those organisms that does eat sugar. So it does tend to, on processed foods, it does, and cakes and soft drinks and things like that, you tend to get a flare-up of acute symptoms with that as well. So it's often just eating predominantly whole food, plant-based, mostly high fiber sort of foods. We know that fiber itself is associated with improved clearance of Giardia, for example. And then it's using the right herbs. And years ago, I used to use primarily Coptis chinensis, which is high berberine herb. Just high doses for 10 days. Great outcomes. These days, I tend to use probably more things like pomegranate husk, guava leaf, oak bark, propolis, ribwort. There's a number of herbs there that I perhaps see as having more nurturing effects on the colonic ecosystem lower down, but not that I'm actually particularly worried about 10 days dosing of high dose of Coptis, because I'm really not, but it just tastes pretty foul. And I find some of the other herbs are more palatable. Yeah.
Is that your favorite, like, berberine containing herb? Because you use that a lot, that Coptis.
Yeah, it is. And to be honest, I don't use it so frequently anymore, because maybe partly because it's just changing patient presentations compared to 10 years ago plus. But when I first started playing with Coptis, I remember making a tincture with pretty basic supplies, like a home blender. Blend it with some alcohol, let it sit. And then I was lucky to be working at Southern Cross University at the time, and I was helping out with a phytochemistry lab, and we actually run an HPLC. And I brought in my Coptis tincture to compare it to the golden seal tincture and the Oregon grape and the barberry tinctures that were available, and it was a powerhouse of berberine. It had, I think, at least 3 times more berberine than golden seal, and heaps more than Mahonia or Purus vulgaris that weren't even comparable. So for that point, I was like, this is my the herb of choice from a berberine perspective, because it's much higher, and at the time that the raw material costs were less than with golden seal.
Right. Well, one of the more popular ones in these compounds now is philodendron.
Yes.
Do you find, I find that, I would say my favorite still in a tincture form would be Oregon grape, just simply because I love that herb, and I use it in a lot of different ways, but as a standalone, I don't know about philodendron for berberine content, so I haven't used it. It's actually,
it's definitely higher than Mahonia. It's been a while since I've looked at the stats around that. And I used to make a tincture of philodendron years ago, and it was quite a lovely tincture, actually, because it had these sort of demulcent qualities that came out when you made the tincture, as well as the sort of the bitter berberine compounds. So it actually felt like a nice gut tonic in that respect, because you get these sort of demulcent, mucilaginous type qualities alongside the antibacterial qualities. But it was certainly less than Coptis, but I think it's because it grows on a bigger tree, it's easier for commercially extract larger quantities from philodendron than Coptis, which is that little plant that grows in, hard to find, rainforest, probably covered valleys. That's, small plant that takes probably years to get the root up to a harvestable size. Probably a bit like golden seal in reality, whereas it's much. Well,
good to know that that Giardia is quite responsive then to high dose berberine. Good to know.
And I'd often use probiotics alongside that too, like things like L-plantarum 299B, L-renosis GG. I do have, particularly LGG has got some good animal studies, which is the best data we have on helping to eradicate Giardia. And listen, even in most people, you do nothing, 90% of people will clear the Giardia on their own in 4 weeks. It's just, it can be very unpleasant 4 weeks. We can shorten that to 1 week or 10 days. That's obviously a much better bet. And there'll be that small percentage of people that aren't able to throw off Giardia on their own. And that's perhaps what I see more in my practice now.
And it's, I always associate Giardia with camping and drinking out of streams when I lived in the Pacific Northwest, and not that I ever did, but that's what I was taught. And here, is it like where do we find it here in Australia?
I would say it's probably not too dissimilar, that it's often in creeks. Yeah, okay. and all it takes is someone at one of those rainbow gathering festivals to.
Oh my God, we're going to get hate mail, Jason.
Have some sort of fecal matter go into. Sorry, I love most aspects of those festivals. Sorry, it's just that just goes in my mind, because I just remember these outbreaks that would occur from some festivals where I don't think they dug the pit toilet quite far enough away from the river system that everybody was swimming in. And you know what the rains are like up there. There can be just huge amounts of rain. Some Giardia gets to the creek, people drink or inadvertently drink some while they're playing in the water, and then.
Luckily, we've had just masses of water here in the past couple months, so we're really happy that our streams are, be there, Giardia filled, but hey, we love it.
I remember, but I'll wash downstream now. And I picked up Giardia from drinking creek water up that way. For example, that was my first experience of a diarrhea. Protozoal origin was Giardia. This is before I was a naturopath.
Let's kind of go back to testing for just a moment, because, but just because it was like a conversation I had, or I think it was a lecture from Ilana Gurevich, who's a well-respected naturopathic doctor and IBD specialist, and she talked about parasites, and that parasitology as an actual science is sort of like a dying art, that these parasitologists are really, well-trained parasitologists are a dying art, because everything is now PCR and stuff. But there's a lot that can be also macroscopically I get patients, I don't know if you get patients like this, but they fish something out of the toilet that they have passed, and they are convinced it's a parasite, right? So, and sometimes it looks very darn close to something weird, and you send it to the lab and it just says negative for, macroscopically, microscopically, there's just nothing there. Has that happened to you?
Yeah, I've certainly had patients that have done similar things too. And I think it's been great to have a resource of someone like that can actually just look at it probably under a microscope and just go, okay, is that just a vegetable fiber of some description that looks a bit like a worm, or is it actually something that is a worm, for example?
Well, just recently, I had a patient pass an actual intact caterpillar. It was like he has a lot lot and microscopic colitis, but it was so fast, his transit, that he ate some kale, and the caterpillar came out the other end intact. So, it does happen when you have a transit of 20 minutes or 30 minutes. So that was a first, though. That was definitely a first. But I've had
first I've heard of such a thing too.
Yeah, and it was bizarre. So, so you also get some of those odd mason jars that end up on your desk saying, what is this? I've just passed this. And, there are things like gastrointestinal lining or shedding when there's massive inflammation that can also look like ropey kind of mucilaginous worms. And just talking out loud for the listener, because, sometimes we think we see a parasite, but it actually isn't. And there just is so much I find misinformation about parasites on the internet that I really wanted to clarify that I actually, when I test for it, I don't find them often. Then there's also an argument that they hide out. They hide out in areas like the gallbladder and in the mucosa. And there is some evidence around that with, especially with gallbladder issues. So what are your thoughts on that, Jason?
I think that, I would probably concur in terms of my clinical practice. Reality is that I don't think that these things are nearly as common as you might guess from reading the blogosphere. But I do think there certainly are some organisms, and I'm probably more familiar with things like Salmonella that can, which isn't obviously parasites, a bacterial organism that can sort of get up into the gallbladder and make it hard to actually deal with. And I think there probably are some other organisms that have that same capacity that I'm less familiar with as well.
Yeah, sometimes, what do you think about, I've started to, before we do stool testing, like the stool testing that you promote and that I promote from different labs, sometimes I give a biofilm disruptor. Do you find that to be helpful? Just as a week or so before, to try to disturb and irritate any sort of potential pathogens to come out of their hiding so that they're easier diagnosed?
Interesting. No, I haven't tried that approach. And interesting thought process. I might think that it might change the ecosystem dynamics as well, in terms of not even just pathogens, but other microbes that also live in biofilm, like many bifidobacteria, lactobacilli, etc. The populations might change in some way when exposed to that too. That'd be my only concern around that.
Yeah, I think of it more like when, symptoms aren't like just as a retest, as a potential, where we might get more bang for our buck, because we know those stool tests are so darn expensive. Just a thought, and I've,
Yeah, and we're still, oh my God, we're still learning, as you'd expect. But, I think there was one person that had blastocystis. They did a stool sample every single day. It's been a few years since I read the study, but it certainly did not show up in the stool every single day. It was missing when it came out. So it wouldn't surprise me if it's similar with other, protozoal organisms, depending on the overall quantity in the gut. Etc.
So moving on to our next category of parasites, which are worms or helminths. And recently, for those, I think I may have mentioned this in other podcasts, but there are worms that are obviously like tapeworms that are quite parasitic in terms of eating your calories and attaching themselves to the gut wall like most worms. But there are some worms, not all, but some like hookworm that are used therapeutically to induce sort of or down-regulate an immune response for those with IBD, I believe. So have you had any experience with that?
No. I mean, I've certainly read the studies around it, and I've read some of the preliminary data looking at, I think it was American hookworm for celiac disease. For example.
Celiac disease. Yeah, the Necator
the original
Americanus,
research was less than exciting, but that it like slightly decreased the amount of inflammation induced by gluten, but actually caused pretty severe symptoms at the time they were inoculated. So it's like, but they may have fine-tuned their approach since I've looked at that research. But I think you're right around IBD. There's more consistent positive data around that.
So just as a take home, that not all the use of those kinds of things is not always pathological. It really can actually be therapeutic administration of. And that really speaks to the fact that even creepy as it might be, but we all have had. We've all evolved from that in terms of our microbiome used to be. It's not all just bacteria and some fungi and some viruses. It was creepy crawlies as well. Right?
It's true, and you're right. And I think you hit the nail on the head with the evolution aspect. Is that our immune system, our gut, gastrointestinal system has evolved with, this constant interaction with bacterial species, fungal species, protozoal species, and you're right, helminths as well, that have allowed it to evolve in a certain ways. And we take that sort of interaction away, there are consequences. And certainly we're seeing the consequences of bacterial dysbiosis, I think, all around us now. But I think we'll as research moves on, we'll be teasing out the consequences of the lack of, diverse fungal ecosystem, a lack of diverse protozoal ecosystem, and the impact that has, and potentially, and there's some discussion around that lack of helminths as well as having some impact on immune overreactivity to certain things that it shouldn't be overreacting to.
Yeah, we've become too hygienic, and that's just why I always love your message of treating the terrain rather than just the individual organisms. I think that's a very holistic approach and much more aligned with my view of that. We got to get away from this one bug, one disease, or that kind of approach. So, but sometimes it's kind of harrowing when you get these test results back and it's just like a desert in somebody's gut. It's like, wow, I'm not surprised you can't get up in the morning, your energy is in the toilet, and you're aching all over, and you've got diarrhea or whatever maybe. It seems to be like a long journey back for some people, and they have a lot of issues systemically. That's correct. And it just makes me think when you mentioned that of, a patient I had that had essentially around a 0% diversity score and 0.6% butyrate producers. I kid you not, 0.6%. And keeps very high hydrogen sulfide gas producers and LPS like crazy. And you're like, this person was only eating, one, essentially just chicken. By the time when they gave this to me, just chicken, 2 chickens a day. That was it. And you look at that ecosystem going, gosh, I can see why you're feeling so horrible. And I can see why at this point, any plant food causes you symptoms, because the level of inflation in your gut is surreal, but you also need to nurture those species and feed them for any chance of your gut getting better long-term. So it is fascinating to see that correlation between disturbed ecosystem disturbance, dysbiosis, and then, can be quite severe level of symptoms in many. Yeah. And, I think you and I see a lot of this sort of microbiome decimation. And do you, at that, for someone like that, is it too hard to coax it back into a viable microbiome? Or do you think about FMTs or, fecal microbiota transplants? I think, is that a good viable option for these people?
I think for some of those people, it definitely is. It's just trying to find the donor that has the right ecosystem to donate to fix up those gaps. Which in a case like that, I reckon it's probably pretty easy because it's so disturbed that probably almost everybody's will be better than what that ecosystem actually was. Other people, it's challenging. But in terms of, with this particular patient, we've actually made a pretty through her efforts in keeping in incorporating new things into her diet and putting up with levels of discomfort is part of that process, because any intestinal gas causes that's produced causes abdominal discomfort when the gut's that inflamed, which is in her case. So it's been her dietary diversity is far better. Her symptoms are actually far reduced, systemically, and a whole range of other symptoms are reduced. But we're about to do a second follow-up stool test, so we'll see what sort of impact there actually is. And I've been surprised at times at how resilient that ecosystem actually can be in some of these people where it looks pretty horrible, like the ecosystem looks very damaged, looks very low in diversity, but with the right tools and the right effort, the right lifestyle stuff, that we're actually able to restore a certain degree of normality. Now, obviously, if species are extinct, they're extinct. And this is the thing, you don't necessarily know until you attempt to revive that certain bacterial populations, whether they come back or not. And that depends whether they can handle the treatments that help bring those species back as well. But I think there are some cases where FMT screams out as a potential treatment that much quicker fix in a person like that.
And the capsules have been around for a while now. I think, I talked to Dr. Andrea Macbeth, who on the last podcast about, she teaches at, I think it's NUNM, the microbiome classes, and she actually has a clinic herself, sort of boutique clinic about specific use of FMT. It's still around the C. diff, but that's all coming now, where we're seeing these boutique things. And her and Mark Davis actually have been using oral FMT for some time, apparently. So that's, I think, a lot more, maybe less palatable, but a lot easier than doing an FMT through the rectum. But it's all it's going to be very interesting moving forward.
Yeah, I bet it will be, and I look forward to when we start doing fecal banking for kids before they ever get exposed to antibiotics. We'll take a lovely specimen to reintroduce their ecosystem back in, and then we sort of takes away many of the concerns that there are out there about FMT, introducing new organisms that may not be the good match for that person, or obesity or depression or anxiety that might get passed from person to person. It takes all that aspect away. So I look forward to that. And just that burgeoning research on the impact of FMT for a range of other conditions, because it's pretty well proven to be helpful for things like C. diff. But there's a growing body of research for IBS and IBD, and I think we'll be looking at using it to treat depression, anxiety, for type 2 diabetes, obesity, coming up. So it's like there's a whole bunch, anything that's associated with microbiome disorders, which is a lot. Alzheimer's, Parkinson's, multiple sclerosis. I think that there's a huge avenue here for fecal microbial transplants to actually impact that. As there is for gut microbiota modulation, which is perhaps where my clinical practice is really at, is optimizing people's ecosystems, and I'm not actually doing the FMT so much as people, Mark Davis, for example, but I look forward to seeing that sort of research, because I think for some people that could be a quick, viable option. They just have to get their head around ingesting poo, and that's a bit of a leap for some people, whether orally or rectally. I think you're right that for many people, it would actually be easier to do capsules, but to get their head around orally ingesting feces is trickier than using rectal administration.
I think that those people that are, some people are just at the end of their rope. So they're like, at that point, I think sort of, they don't mind it as much. Okay, before we wrap up, this has been really extremely helpful. So again, for people listening, I'm not quite done. I still want to ask you about, what's the latest and greatest on the probiotic front in terms of particular strains dealing with issues like SIBO or hydrogen sulfide, or a number of things that we've discussed before. So I still want to have you talk about that. But before we end, definitely check out the Probiotic Advisor if you're a practitioner. It's a great tool to quickly search for recommended strains that have been researched, particular conditions, and also the blastocystis and Dientamoeba course will be on the show notes, and also we still have the microbiome restoration course by Dr. Jason Hawrelak on the SIBO Doctor. So you've got a lot of resources if you've just tuned in for the first time and you're not sure where to start. So back to you, Jason, in terms of what's the latest and greatest on the probiotic front, other than crapsules.
But I think there's things I look forward to moving forward into the future, and that certainly crapsules, and I would say that probiotics made from Fecalibacterium prosnitzii and Acromasium eosinophila, but I think they're still a few years away, and even Oxalobacter formigenes again, which is
that's great news. Yeah,
a couple of years away, but it's all happening. So at some point, we as clinicians and the general public will have access to a range of tools that we don't now, that will actually open up, I think, a range of treatment opportunities that and a range of butyrate producing bacteria in a capsule will be fantastic, because so far, our probiotic dispensary is so much focused on lactobacilli and bifidobacteria. Even if they're using 12 strains of bifidobacteria, it's still just bifidobacteria. We're not looking at the dominant organisms in healthy people's gut, which could be Fecalibacterium, Eubacterium, Roseburia, these lovely butyrate producing bacteria. So again, I'm super looking forward to what the future holds in terms of future probiotics that will potentially allow us to recolonize in a way that current batches don't, and reintroduce a more diversity of ecosystems. And I think there's that Canadian study that used a product called Repopulate, which I love the name of. And essentially it was, they essentially took the poo out of a fecal transplant and just concentrated up the microbes. So the FMT without the F. and that has, I think, better compliance rate, because people aren't going to be so concerned about without the fecal component, and as ways of repopulating the gut in a way that we can't.
Fantastic. Thank you so much for spending some time with me again. And all those resources will be in the show notes, as well as how to find Dr. Jason Hawrelak and work with him. Are you still actually taking new patients, Jason?
Yeah. There's a
two-year waiting list now?
A queue for the most part, but for people... Yeah, except for emergency cases that sometimes get slotted in very quickly.
Okay,
people
very
need help
good.
ASAP, or they lose their colon, for example.
Oh, yes,
sometimes
yes.
he's slotted in more quickly.
Excellent. That's good to know. But yes, he is in beautiful Hobart, Tasmania. So if you can make your way down there, it's a beautiful part of the world. Thanks again, Jason. Always a pleasure to talk to you, and I'm sure I'll see you soon at one of these conferences.
You will, Narella. Thank you. It's been great being here once again.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.